Hello everyone, Miss Goolsby here with Phlebotomy, Chapter 11, Special Collections and Point of Care Blood Test Lecture. Today we'll be covering some objectives that talk about the special procedures that you would need to do for certain kinds of collections. One of the most important and also the most dangerous if you don't get it correct are for blood bank tests. You have a certain very extensive patient identification and specimen labeling procedure that you would do for blood bank tests. You would also have to identify the type of specimen that is required for the blood bank department. For blood bank, that's the area where if anyone needs a transfusion, then they would be given blood products. So that's the area that if you misidentify a patient and they get the wrong blood type, there is a potential to kill that patient. So it is always important to make sure that you identify the patient correctly, but especially important in blood bank tests. Number 2, you're going to demonstrate knowledge of the special collection procedures, the terminology, the importance for certain labeling, timing, collection, and handling. Number 3, describes sterile technique in blood culture collection, and I discussed this with you already, but blood culture collection can be done at the same time as you do other blood specimens, but these need to be done with different methods in order to ensure that you don't have any kind of contamination. So we're also going to talk about why that's so important. And also, you need to know why would a physician might order a blood culture? Like, what are the reasons? Really, the reason is, in a nutshell, they want to know, does this patient have sepsis? And in that case, when you have septicemia or bacteremia, this means you would have a bacteria or a fungus in the bloodstream, which can be very serious, and the patient can die from this. So it's very important that they get on the proper antibiotics immediately. And then lastly, we're going to talk about point of care testing, POCTs. We're going to explain the principle behind these and give you some examples and any special equipment you might need with those. Okay, so we are going to start with blood bank specimens. Blood bank specimens, this is for transfusion, so remember this is when they are getting a blood product. The identification and labeling requirements, please make note of these. They have to have the patient's full name, not just first name, full first and last name, and if they have a middle initial on there, the hospital ID number or social security number, the patient's date of birth, the time and date that you collected that specimen, and also your initials. Okay, so a second thing that the blood bank requirement is, since it is so strict, any kind of labeling errors, remember, of any kind, if you send a specimen for blood bank up to the lab and it's not labeled, it is not going to be accepted. This also pertains to specimens drawn in the emergency department and operating room. When someone besides a lab personnel collects that specimen, the full name of that person or their numbers, whether it is a physician or a nurse, must also be on that label. So whoever collects this, it can't just be their initials. If it is not someone from that lab, then it has to be that person's full name and what they are, whether they are an RN, whether they are respiratory, whatever they are, a doctor, whatever it is, that's got to be on the label. An error in identification or labeling, if there is any kind of error there or anything questionable in blood bank, then it will be sent for a recollect. And in that causes a delay in the patient being treated. And remember, anytime a patient needs blood products, they are very sick, and this is serious. So this needs to be taken very seriously. You don't want to send any kind of specimen to the lab that might actually cause that patient a delay in their care. Okay, let's say that error doesn't go detected. So an undetected error can mean that that patient gets incompatible blood products and possibly has a fatal transfusion reaction. So not only, again, not only is it very important to never mislabel a specimen, but especially in blood bank. Okay, the Joint Commission has 2 patient identifiers, okay? There needs to be at least 2 patient identifiers. Neither should be the patient's room number, because remember, these patients can get changed from the rooms, especially if they come in from, like, say they're in ER room 2. You need to get something besides that, because that patient is probably either going to the operating room, they are going to an actual room on a different floor. So that does not need to be one of those identifiers. When you are administering any kind of blood product, when you are doing anything, you can kind of check that, but just keep that in mind that that patient may change rooms. So anytime you're taking these specimens, you're going to have to keep that in mind. Another thing for the special identification system for blood bank is that blood bank usually has their own ID bands, and they call them BBIDs. These are designed to protect the patients and the healthcare workers from errors that could be fatal during identification and administering of these blood products. So some companies have handwritten little carbon labels that are like a bracelet. Others have pre-printed labels that have the barcoded BBIDs, and they can be printed in the lab with the requisition, or if you have a bedside printer, it can be printed there. But this band has a unique identification number on each patient. And so what this does is this ensures that the blood specimens are correctly identified with that one person only. So you're not only going to have now the patient's hospital band, but they also have a blood bank identification band. Okay, and this band for blood bank, the numbers are going to be different. But what they're going to do is they also have these little stickers. These little stickers can be stuck on the blood products that are matched up for that patient. So that way, when it's sent to the lab and this is cross-matched, meaning that that patient's blood product matches. When they did the testing, there was no problems. So now that particular blood product is set aside for that patient, they're going to put those little stickers. That unique identification number for that sticker is on that unit of blood, and then that's another check for nursing when they go to give this patient this particular blood product. Then they can again check the patient ID with that little sticker, with that same number that was actually matched up in the lab with that patient sample. So all of these are just checks and double checks to make sure that there's not going to be the wrong blood product given to that patient. Okay, specimen requirements. You're going to need to send either the lavender or the pink top EDTA tubes. So the purple tops is what we call them, but lavender or pink. Non-additive red tops can also be used, but if they're going to have a preference, it's going to be the purple tops. The different tests that you need to be familiar with is that they do an ABO-RH. That means they're doing a type and screen. So this type and screen means they are telling in the blood bank, they're just getting ready in case they need a blood product, but this doesn't mean they have been matched up with any blood products. So let's say that this patient is scheduled for surgery, but this surgery, they may not need blood. Then they are going to do the type and screen, which means they test for their type, their blood type, whether they're A or they're B or they're AB or they're O. And then they're also going to check their RH factor. So if you've ever heard anyone, for example, my blood type is O positive. So that means I have O blood type and I'm positive for the RH factor. So if I were O negative, then that would mean I would be O blood type negative for the RH factor. Okay, so that's what that means. So if your patient has just a type and screen, then that's all that's going to happen. That doesn't mean they have blood products matched to them. That means they have their blood type ready should they possibly need any while they're in the hospital. Okay, if they do another test, which is called a type and cross, then this means they check their blood type and they do a cross match with a certain blood product. So like for me, example, I'm O positive. If I were in the hospital and they wanted to do a cross match to say I needed a unit of blood, then they are going to pick an O positive unit and they're going to test my blood with that blood. And if it does not have any discrepancies, if there are no problems, then that means that that unit is now set aside for me while I'm there. So just in case I need it, or maybe I for sure do need it, then they're going to now, once they do the cross match, if there's no problems, they know that now that unit is fine to be given to me. So they're going to match it up with the stickers on my BBID band and my hospital band, and they're going to make sure that all of that, while the transfusion is given, that I don't have any reactions. Okay, so this is just a picture of a phlebotomist comparing a labeled blood bank tube with a blood bank BBID, which is a blood bank identification bracelet. So they're just comparing the number on the tube with the number on the bracelet. Okay, again, just another check. But do you see in the blue box there where it says that you need, as far as patient identification, you're using at least 2 patient identifiers, neither to be the patient's room number. That's what I was talking about, how the patient can be moved. Whenever you are administering medications or blood products, taking blood samples like you as a phlebotomist would be doing, and anything, other specimens that are, as far as the testing is. Okay, now let's talk for a minute about blood donor collection. Blood donor collection is a little bit different. This is when you go, like, say, to United Blood Services or Vitalant and you donate blood. This does also involve a screening and collecting process. If any of you have ever donated blood, you know that they ask you a bunch of questions on a questionnaire. There's certain things that mean you can't donate right now. There's certain things you can't donate indefinitely. You'll never be able to donate. And also, they do a quick hemoglobin test, which means that you have to have a hemoglobin of no less than 12.5 or a hematocrit of no less than 38% to be able to donate. And this is not because of the blood product as much as it's for your safety. You don't want to be donating blood if you don't have any to donate, if you don't have enough yourself to be able to donate. So anything that is blood donor related is collected from volunteers. If you end up, say, sometime working in a donor collection facility, this does require special training because I talked to you about the sizes of needles, and you know how the number goes up. Then as the number goes up, the smaller the diameter of the needle. Like, for example, most butterflies are 23 gauge. Well, when you are in a blood donor center, you can use 18 and 19 gauge needles. So those are really big needles. Sometimes they have certain setups where they don't even allow a phlebotomist to just jump right in there. They have to fully train you step by step to be able to do blood this way, to be able to draw blood this way. So there is guidelines they have to follow, and these guidelines are set by what we call the AABB. This used to be called the American Association of Blood Banks, but now it's just known as AABB. So this is an organization that develops the standards, and it accredits any kind of blood donor systems. It focuses on this patient and the donor care and the safety. These are also regulated by the FDA, because I don't know if you know this, but blood and blood products, when you give them at a donor center, these are now considered pharmaceuticals. So this is why the FDA has a hand in these blood products. But all potential donors, going back to that, they got to be interviewed. So to see if you're eligible. Some things that you need to look at on the donor eligibility for this slide. You need to be between, this is not everything, this is just a few things. Between ages 17 and 66 years of age, you need to weigh at least 110 pounds. As far as physical exam, it's a brief physical exam, as in just to make sure that you are healthy for that day, not running any fever, blood pressure, things like that. You do have to fill out a medical questionnaire. You have to have written permission from the donor to be able to say that these products will be used. They won't know, you don't pick who they go to and so on when you just go in there and donate. These are collected in units. So, if you've seen the blood bags, these are collected in a whole bag. They're not just collected in a tube. And so that's a little bit different. You're going to have a lot more blood that you're going to give rather than just going to get some testing done. If you're going to give whole blood, when you go in there, you need to make sure that you feel good and that you're generally healthy at the time. Okay, you don't need to go in there with a fever. You don't need to go over there just having the crud. Make sure that you are healthy, because you don't want to take a risk that you have something and you don't know about it. You're going to pass it along to somebody. And as far as at least 17 years old, in some states, you can be 16 if you have parental permission to donate. But, most of the time it's 17. You don't see a lot of 16-year-olds volunteering to donate anyway. All of this donation information is strictly confidential. So besides giving them written permission, they need to know that all of this will be kept confidential. Every question they answer, all of that. Okay, a couple of things that you also need to keep in mind about blood donation that's not on this slide. These are normally collected from a large antecubital vein, your big AC vein, because that's the best one to get lots of blood out of and not have any problems, in getting the whole bag full. There is a list of your principles on box 11-2 in chapter 11. It is a blue box. If I were you, I would jot that box number down and go look at those donor unit collections. It is box 11-2. That's where I'm talking about this information. You're going to select the vein just like you would a routine venipuncture. You're going to clean it similarly, but you're going to clean it in a little more. You're going to go into a little bit excess with the clean. That collection unit, which is that bag and the tubing, it is a sterile closed system. So that bag is, when it's running through the tubing to get to the bag, it is sterile. Nothing can get to it. There is, in that tubing, it's going to fill it by gravity. So this bag has to be placed lower than the patient's arm. And the collection bag has an anticoagulant in it as well as a preservative. And that bag is going to be placed on a mixing unit. So while it is being drawn, it is also being mixed on an automatic mixer to keep it from clotting up. It's filled by weight, but typically it contains around 450 milliliters of blood when it's full. Another thing that it does not tell you in this slide, but you do need to know, is that only one needle puncture can be used to fill 1 unit of blood. If the unit is only partially full, and say that vein is starting to blow or it's not coming out anymore, and say they've got to stick the patient again, then you can't put that next unit, you can't put that amount of blood in the second stick in the same bag. Okay, you have to have a new bag and collect a whole new unit. That's very important to know. So don't put blood, even if it's the same person, don't put blood from 2 separate sticks in the same bag. Okay, there is a process called the look back program. This is where a unit of blood can be separated into the different components. Like you can separate that full unit of blood into the different components of the blood, such as you can have RBCs only. You can separate it out of plasma. You can even separate it out into granulocytes, platelets, and coagulation factors. All components have, no matter how many units that you separate this out into, these components, each of these components have to be traceable to the donor. So this is what is called look back. This means there is meticulous record keeping. So look back means tracing and testing the blood donors and the recipients when a blood product has been determined to be potentially contaminated with a bloodborne pathogen. So let's say that when they're doing these testing on these units, if they find that one has a pathogen in it, like a bacteria, they need a way to trace this back to every product that came out of that patient's blood. So this means everything has to match up, okay? But this can only occur when the blood service is made aware of the possibility of the transfusion-related infection. So like this means, let's say this unit went to the hospital. This unit then was transfused into a patient. This patient then got a septic type infection and they traced it back to that unit. Well, then that hospital is going to notify the blood bank that they think that's a possibility of where that came from, that that patient got that. So then they need to be able to match that up with any other product out there that was possibly sent, say, to a different hospital or a different location. They need to be able to notify every one of the blood recipients to know that that's a possibility that there was an infected, contaminated unit. Okay? You got to be able to verify the unit numbers, when it was collected. If it's currently in inventory, then it's pulled out of inventory. Let's say it wasn't given to a patient yet, or maybe part of it was not. Then they need to be able to pull, let's say that the RBCs were given to a patient but not the platelets. Well, if the RBCs are what look like they caused an infection, it doesn't matter. They're going to pull everything in the whole unit. So that means if the platelets haven't been given to a patient yet, they're just going to pull them from the hospital and send them back. Okay, autologous donation. This means if a person knows they're going to have surgery, say it's an elective surgery, not an emergency surgery, they know ahead of time, they know that they're going to possibly need blood products, then you can go and donate blood for yourself. That's what autologous is. So, if you don't want to risk a possible transfusion reaction with someone else's blood and you know ahead of time, then you can just donate for yourself. So this is where you go in pre-operatively and you actually donate for yourself. It does need to be several weeks before the surgery because you don't want to deplete your blood supply before you go into surgery. But the minimum time between donation and surgery must be more than 72 hours. The more the better. You don't want less than 72 hours, though, between the time you donate and the time you're going to have surgery. You also have to have a written order from a physician and a hemoglobin of at least 11. Notice that is not the same hemoglobin as if you were to go in and donate blood. If you go in and donate blood at a donor center, you need a hemoglobin of 12.5. But if you're going to donate for yourself, then you can have a hemoglobin of only 18 and still donate. If you're going to donate at a blood center and you have a hematocrit of less than 38, you can't donate. But let's say you're going to donate for yourself in autologous, then it can be as low as 33% for your hematocrit and you can still donate. But this is also why, let's say you have the surgery, then you don't need the blood, then that blood cannot then be given to another patient. It has to be discarded because it does not follow the regular rules for donor eligibility for regular units. Okay, so There's a lot of things that were not taken into account, such as the patient's history and so on. So you can't just say, oh, this person didn't need it, I'm going to give it to this one. That doesn't work that way. So you're going to have to make sure that, well, you don't have to make sure. There's nothing you're going to do. But that's just the facts. If you don't have to use that unit for yourself, then they just discard it. They throw it away because it doesn't meet the same safety standards that the others do when they're donating. Okay, another thing is called cell salvaging. This means that this is a medical procedure to recover blood that is lost, your own blood, that is lost during surgery, and re-infuse it back into the patient, okay? It is a type, we said autologous is donating for yourself, but ahead of time. Cell salvaging is a type of autologous blood transfusion that is done during the surgery, okay? So you have to have a lot of things in place for this to work, but it is recommended that the salvage blood be tested for residual free hemoglobin prior to reinfusion back into the patient. So if the patient has a high free hemoglobin level, this means that too many red cells were destroyed during the salvage process. And if you then put that into the patient, these lysed red cells, then this can cause them to have kidney problems. So they can have renal dysfunction if you put that blood back into them. So there's something that we do, and this is a test. You can test this free hemoglobin by using a point of care instrument called the HemoQ. This HemoQ is a plasma or low hemoglobin analyzer, and if you're looking at your book on figure 11.4, it shows you just a picture of the little red HemoQ analyzer. Okay, let's get off of blood bank products for a second and get into blood cultures. Blood is normally always sterile. You should never have like even one bacteria floating around in your blood. It should be sterile. However, bacteria does enter the circulatory system from different sites. If they do find their way into the bloodstream, then the body's immune system tries to clear it out fast, but if it does not clear it out fast enough, then the patient ends up with what we call a BSI, which is a bloodstream infection. This means that the organisms or their toxins are in the blood, and this is called septicemia. There's a couple of other words you need to be familiar with, and one is bacteremia. Bacteremia means they have bacteria in the bloodstream, and this is not the same as fungemia. Fungemia is when the patient has fungi, such as yeast or mold, in the blood. So these are treated different. They have antimicrobials for fungus, and they have antimicrobials for bacteria, but they are not the same antibiotics. So this is why it is important to differentiate between whether they truly have a bacteria or do they have a yeast or a mold in there. So when the doctor suspects a BSI, which is your bloodstream infection, they're going to order these blood cultures. These blood cultures, when they take them back to the lab, if the patient has one, it can also go into identification of the exact organism. And then when they grow it out, they can test to see which antibiotics work the best against that organism and make the organism go away. And then the doctors, when they're looking at the test results, they can change the patient's antibiotics if they're not on one that's working. So it's assessing the effectiveness of whatever antibiotic they have them on in the first place. Okay, last thing on there, another reason why blood cultures are ordered if they suspect, of course, the BSI, but look at the bottom down there. Presence of FUOs. You need to know what an FUO is. That stands for fever of unknown origin. okay? This means the patient has a persistent fever with no obvious cause. This has usually been linked back to a BSI, like a bloodstream infection. But the symptoms, if a patient has a BSI, they'll have not only fever, but they'll have chills, malaise. Their blood pressure will sometimes bottom out. And if it's real serious, they can have changes in their mental status. So this is, it's extremely important that this is caught early. Okay, BSIs trigger life-threatening inflammatory responses if this gets serious, and this is where it is called sepsis. But this anti-inflammatory response that kicks in, this means the patient can go into septic shock. They have a dangerously low blood pressure. They also have circulatory and metabolic problems going on at the same time. And if that happens, that increases the likelihood that they will die from this bloodstream infection. The CDC says that 1 out of 3 people who die in a hospital did have sepsis. So this is why, as a phlebotomist, if you work in especially a big hospital, you will be drawing blood cultures all the time on patients that have fevers. Okay, specimen requirements for blood cultures. One thing, and it's talked about on the next slide, but is timing. So let's talk first about what the actual specimen is. You're going to collect 2 or 3 blood culture sets, 2 bottles. You will have an anaerobic and an aerobic bottle in one set, okay? So 1 aerobic bottles, those organisms live in oxygen. If it is anaerobic, those organisms cannot live in oxygen, okay? An means none, anaerobic. So you're going to draw 2 sets. You're going to draw 2 bottles in one set, You're going to draw them 30 to 60 minutes apart unless your patient is in critical condition. So timing is really important. They're going to be collected in special bottles, and I already said an aerobic and an anaerobic. Let's get over here on the timely. You want to collect it as close as possible to the time ordered. You also want to obtain a second set from a separately prepared site on the opposite arm if possible. So when we're talking about amounts down there at the bottom under the recommended volume, for adults, the recommended volume of blood is 20 to 30 milliliters per blood culture set. If it is an infant or child, the blood volume draw should not exceed 1% of their blood volume, so much smaller amounts. And the pedia bottles, the peds blood culture bottles, are much smaller than the adult blood culture bottles. Okay, there is a key point. There's actually 2, but there's a key point in your book on page 398. And this key point talks about most bacteria that cause these BSIs, they are caused by aerobic and facultative organisms. Facultative means they can live with or without oxygen. So most are not anaerobic. Most are aerobic or either facultatively. So let's say that you're drawing it and you don't get quite enough, or maybe you're drawing it in a syringe first and then putting it into the bottles. Or let's say that you think this patient's going to be a hard stick and you might not get a great specimen. If that is the case, then you're always going to draw the aerobic bottle first. Make a note of this, and I said this in class. Always draw that aerobic bottle first because, remember, most all BSIs are caused by aerobic or either facultative organisms. So if we're going to try to make sure we catch whichever bacteria it is, we want to make sure that we definitely get it into that bottle, since that's where most infections end up, in that one, instead of the anaerobic. Anything that's left, put it in the anaerobic, but put first for the aerobic, okay? Okay, the specimen procedure, the collection procedure for blood cultures. Besides being in these special bottles and these sets of two, a lot of the problems end up being contamination from just regular normal organisms on the skin. And this goes back to us in the phlebotomy area. If we do not get rid of the organisms on their skin and then we put those skin organisms in that blood culture bottle, then we are contaminating that blood culture bottle. And this is going to prevent the doctor from knowing whether this patient has a true BSI or is this really just an infected, is this a contamination? So it is very, very important that you clean that site very well. The doctor shouldn't have to just decide, is this a mistake? Is this a error that happened in collection? They should not have that as a possibility. So what does the word sterile mean? Sterile means free of all living organisms. So it's not possible to completely sterilize a blood culture site, okay? Because we have bacteria on our blood, on our skin all the time. But sterile technique means we are going to go beyond using just regular alcohol for like a routine venipuncture. So this means it's going to vary slightly depending on the lab that you work at. So you're always going to follow the protocol of your lab. But this is the basics. It's going to require a 30 to 60 second, what they call friction rub, which means we're scrubbing it to get to the bacteria beneath the upper dead skin cells on the surface of the arm. You can use tincture of iodine, chlorhexidine gluconate, and a povidone iodine 70% ethyl alcohol combination. All of those have been shown to be effective antiseptics. First off, backing up to what is an antiseptic. Antiseptics do get rid of bacteria, but they are safe for human skin. Okay, these are different than disinfectants that are used on living skin, okay, like your tabletops and such. Okay, if an iodine preparation is used, you do have to clean it from the site using alcohol or another suitable cleanser after the specimen has been collected. Okay, you don't want to leave this iodine on the patient's skin because some patients do have an iodine sensitivity, and if they do have a sensitivity and know about this ahead of time, then you can use chlorhexidine gluconate or something else acceptable to clean the site. But the sterile technique doesn't just involve the patient's arm. This also involves the equipment that you're going to be using. So this means these blood culture bottles, when you pop the cap on them, you're also going to wipe the caps of those off with alcohol. We want to make sure that we don't have anything on the tops of those bottles that could also go into the bottle. So you're going to clean the tops of those bottles before you put the blood in there. Okay, this is just some initial specimen diversions. These are new devices called SteriPath. These SteriPath have been shown to reduce and sustain blood culture contamination rates. And we won't go into a lot of details on those because if you are using those, they will show you how to use those. But this means this is just a way to kind of eliminate. This is something that they made, man-made, in order to help eliminate some of that contamination. That's the different things, the different companies and what they look like. They just hook onto the bottle and needle there. Okay, so let's talk about media inoculation methods. When you add the blood to the culture bottle, this is called media inoculation. So this can happen in different ways. It can be directly into the bottle during specimen collection, or it can be after collection when the blood has been collected in a syringe. A third way is to use a special intermediate collection tube to collect the sample for inoculation in the lab later, but not at the bedside of the patient. Okay, so these are all different things. If you're going to do direct inoculation, let's talk about that a minute. Then this means you would use a butterfly and a specially designed blood culture bottle holder. If you are looking at your textbook, there is a picture of one in figure 11.7. This is showing a blood culture bottle and a holder to be used with that butterfly needle. So what you would do is you'd prepare the bottles while the antiseptic is used to prepare the site. When you wipe the skin, that starts drying. Then you're going to get your bottle ready. You mark the required fill volume so you can make sure that you fill it to the level. It's already got the little line on there. You remove the cap, clean the top with 70% isopropyl alcohol, those little prep pads. Connect the special holder to the butterfly collection set. Perform the venipuncture like you would any venipuncture. Remember, we fill the aerobic bottle first every time, but this is especially true here because what does the butterfly have in it? It has a tube. What does that tube have in it? Air. So you don't want to put air into the anaerobic bottle. This is why we use the aerobic. This is another reason why we will inoculate the aerobic bottle first because of that tubing with air. You're going to do it just like you do the tubes that you collect. You're going to have it below, where you stuck the patient at. You're going to keep the culture bottle in an upright position as it fills. And then once it finishes, you're going to, take it out just like you would a tube. You're going to mix the container when you take it out of the needle holder. And after you fill both the aerobic and anaerobic, and then you don't have to stop there. If you need more tubes on that patient, then you do blood cultures first, and then you draw any other color tube tops that you need for any other test. Then you take the needle out like you would any other time you did a venipuncture. Pop the tourniquet, remove the needle, activate safety device, discard the needle with the holder and the sharps, hold pressure over the site. Then you would also do one other step with blood cultures. You're going to clean any blood from the bottle tops of those blood culture bottles with an alcohol pad. Blood cultures are always collected first, though, in the order of draw, so remember that. Okay, let's talk about syringe. If we use the syringe method, then this means we draw the patient's blood with the needle and syringe, and then we have to put the blood into the bottles after the draw is completed. And so that's where to fill it, you're still going to fill the aerobic bottle first, and you're just going to allow it to suction. You're going to put the needle directly into the blood culture bottle top. You're going to allow it to suction out the amount that it needs and then do the anaerobic next. You're never going to push extra blood in there. It's only going to pull out the amount that it needs. And then you're going to discard anything that is left in that syringe into the sharps container. Okay, if you collect blood cultures, you're going to keep them at room temp, and they needed to be taken to the lab as soon as possible. If not received within 2 hours in the lab, then this could hinder the detection of anything that grows in the bottles. So it needs to be in the lab within at least 2 hours. Okay, if it's collected in an intermediate tube device rather than the blood culture bottles, then this means you can take a yellow top tube that has sodium polyethanol sulfonate, or for short SPS. That is the preferred anticoagulant for this, tube and for this purpose. You need to know what SPS does. SPS reduces the action of a protein called complement that will actually, destroy bacteria. It also slows down the ingestion of bacteria by the white cells. So, you know, if you're going to use this tube, you still need to get it to the lab and transfer it into the different tubes as soon as possible. And this transfer process needs to be, in the safest way to get it to the lab and get it in the bottles without risking anything for the person that drew the blood, like the phlebotomy. Okay, the collection procedure, I'm not going to read that to you step by step, but notice that most of it is the same. You're going to ID your patient, sanitize your hands, put your gloves on, tourniquet. The only thing that is different in here is that friction scrub, and then you're going to allow it to dry, flip off the cap, make sure you look at the bottle for any defects, just like you would tubes. Clean the culture bottle stoppers. Mark the minimum and maximum so that you kind of know where you're at. Reapply the tourniquet, perform the venipuncture, don't retouch the site. See, all that is the same. This is a picture of the friction scrub. See, it looks like a little sponge. You break the little ampule in there, and that is usually an iodine solution. You break that little ampule and you scrub that area. Then you just flip that little plastic cap off and clean the top. If it is a direct draw, you're just going to fill the specimen directly, and you're going to discard everything, clean off the bottle tops, thank the patient, and that's it. Anything that needs to be done outside of that, like if you're going to draw it in a needle and syringe, see how they did this, and they just hold it directly up and down and put it into the bottles, aerobic first. Okay, the intermediate collection tube. This one is, like we said, we don't really want to do it, so we discourage this because it does increase exposure and risk to the lab. You know, it is what it is. I mean, occasionally it has to be used, but most of the time we don't really want to do it this way. Okay, let's talk about antimicrobial neutralization products. It's not unusual for your patients to be on antibiotics already or on antimicrobials at the time the blood culture specimens are collected. Presence of these antimicrobials, though, they can inhibit the growth of organisms in the blood culture bottle. So in these cases, let's say that this patient is already in the hospital and already on antibiotics. The physician may order blood cultures to be collected in what they call a FAN or an ARD. A FAN is a fastidious antimicrobial neutralization, and an ARD is an antimicrobial removal device. These bottles have these substances in them that help remove the microbials. For example, the FAN bottle contains activated charcoal. That helps neutralize the antibiotic. The ARD bottle contains a resin that removes the antimicrobials from the blood. The blood can then be put on the blood rocker and used just like anything else. Okay, so in this case, ARDs and FANs also need to be delivered to the lab as soon as possible, but you need to know what those two things mean, like what is a FAN and what is an ARD. Okay, this is a picture of a pediatric blood culture bottle. So see how the volume is much smaller. These are from blood cultures from neonates and pediatric patients. These are pretty hard to do because you already don't want to get a lot of blood out of these babies, especially your neonates. The critical part of it is that there are two main organisms called Streptococcus pneumoniae and Neisseria meningitidis, and these can cause meningitis in babies. And this is why these are very important, that we actually isolate these organisms if this is causing a problem in these babies. But there's a different broth to volume ratio. So it is never advised to use pediatric blood cultures for adults or vice versa, okay, because it's not going to be the appropriate broth to blood ratio, and it could end up in a false negative result, which is even worse, because that means you didn't pick up the organism at all, and then the baby does have an infection, but you didn't pick it up. Okay, a couple other things you need to know about the peds. Do not, underline that, whatever you've got to do for the antiseptics, do not use iodine on the pediatrics. You're just going to clean them twice with separate alcohol pads. Don't use the same one. You can also use chlorhexidine for infants 2 months or older, but if you've got a neonate, only use that alcohol twice. If it is 2 months or older, you can use chlorhexidine though, but you never use iodine on the peds population. And as far as how much, what's the volume, then these bottles are designed to accommodate up to 4 milliliters of blood. Okay, catheter considerations. First of all, do not draw blood cultures through an indwelling like an IV or arterial catheter unless there is no other option, because draws from vascular lines have a very high contamination rate, and they may cause your patient to receive antibiotic therapy when it's not even needed. So when you do have to collect them from a VAD, a vascular access device, you're going to draw one set, if possible, by venipuncture and just one through that catheter device. Okay, so remember, we're going to get it in sets of 2 or 3. So if you do this, we don't really advise it at all, but if you do it, only one set needs to be through that device, with the other set being an actual venipuncture, just because of the possibility of high contamination rates. Okay, coagulation specimens. Most coagulation tests are collected in that light blue colored sodium citrate tube, but some special coag tests are collected in a tube that's called a CTAD, which is a little bit different. CTADs are used to inhibit platelet activation between collection of the specimen and the testing. So it was once customary to draw what they call a discard or a clear tube anytime they drew a blue top, period. I'm talking about not even with a butterfly, just to draw a discard. That was to be just one to throw away. But studies have shown that drawing a discard makes no difference in the test results for PTs and PTTs. So a discard tube is no longer necessary when you're collecting these tests. So just keep that in mind. However, there's some debate over whether other coag tests do require a discard tube. So some facilities still draw a clear tube for all coagulation tests. Okay, so what you're going to do there is you're just going to follow the facility's policy. Whatever they say to do, then that's what you're going to do. But a couple of other no-nos are never, ever, ever pour 2 partially filled tubes together. I would think that would be common sense, but I have known that to happen. So make sure that if you're not just trying to get somebody to not call you a recollect in, do not, for the patient's safety, pour 2 small tubes together and make one. That is horrendously wrong. Also, remember, when you do an infusion set, if you do like a butterfly, you do have to do a discard tube in a butterfly, because what happens? We got all that air in the tube, right? So we do have to do a discard tube if a blue top is all we need. Also, when you're drawing from an indwelling catheter, that's the only other time you always draw a discard tube, because of the dead space in the catheter. We don't want air in that very first blue top tube. Okay, now moving on to the 2-hour postprandial glucose. This postprandial means after a meal. So the glucose levels in blood specimens obtained 2 hours after a meal are rarely elevated in normal patients, but may be significantly increased in diabetic patients. So this is why it is an excellent screening tool for diabetes. So in this case, they can also use it as a 2-hour PP, which means it's used to monitor insulin therapy. So timing is extremely important when you're drawing these tests because it needs to be right about exactly 2 hours after. Too early or too late can be falsely elevated or falsely decreased, and that means they're going to misinterpret it and the patient may not be treated correctly. If your test results from a 2-hour postprandial are abnormal, then the doctor may, right behind that, order a hemoglobin A1C. That hemoglobin A1C tells what the patient's glucose is over a couple of months in a row. So this may be like, well, let's just see what it is now. Okay, they may also order a glucose tolerance test. Sometimes you will see this as written out as OGTT, not just GT, which means oral glucose tolerance test. And in this case, this is just another way to monitor or diagnose somebody that has diabetes. There are two kind of disorders they can catch with this glucose tolerance test. It may be that if your glucose level is increased, that's hyperglycemia, and that would be a case of diabetes. Or some people have hypoglycemia, which means their glucose levels are low. So the hormone that is responsible for lowering glucose is called insulin. So this is why diabetics have to take insulin to lower their glucose. The typical glucose tolerance test length is about 1 hour for gestational diabetes patients, but for anyone else, it is approximately 3 hours to be able to monitor them, checking it every hour to hour and 30 minutes. Okay, to prepare for a glucose tolerance test, you do need to know what the patient has to do. They have to eat a balanced meal of at least 150 grams of carbohydrates for 3 days before the test. Then, on the day before the fasting, they're going to fast for at least 8 hours, but not more than 16 prior to the test. They are allowed to drink water during the fast and during the test to avoid dehydration, and because urine specimens may also be collected. No other food or beverage is allowed. They are discouraged from engaging in excessive exercise for 12 hours before the test. Do not smoke or chew gum for at least 8 hours before or during the test because these stimulate digestive process and can cause erroneous results. And they will receive both verbal and written instructions to ensure compliance. So let's say they get there. Once they follow that normal process, you're going to draw a fasting specimen first. This means as soon as they get there, you're going to draw a fasting specimen. You're going to explain the process, make sure they really did fast. Then you're going to check that specimen for glucose. What is that? Okay, you're going to ask them to collect a fasting urine if needed, if the doctor ordered that. Then, if they are there for this full length of the test, the patient is given a glucose beverage. You're going to have to remind the patient to finish the beverage within 5 minutes. They can't drag it out and they can't take 30 minutes to drink it. It needs to be within 5 minutes. You're going to note the time the patient finishes. You're going to start timing and calculate the collection times. Okay, once this is done, you're going to give a copy of the collection times to the patient, and then during those times, they're going to come back to get their blood drawn. You're going to collect the blood and the urine specimens at the computed times. You're going to label every specimen with the collection time, the intervals, and the patient identification number and your initials. And then you're going to take them to the lab ASAP, to be ran ASAP. This is an example of a glucose tolerance test curve. If you're looking, I was looking to see. Okay, yes, on figure 1111 in your textbook, that is a picture of the same one that is on this slide. If you notice the top line, that is where a patient is a diabetic. So do you see how that line goes from 150 up to 300, up to 350, up to 400, and then barely comes back down to 350. Do you see how if someone has a normal curve, look at the stars. Everybody's blood sugar, blood glucose is going to go up after you eat something that has carbs in it. See how this patient is below 100 and then it goes up to 150? And then in 60 minutes, it starts coming down. Then in 120 minutes, we're already back down close to 100. And that is a normal curve. And then it's just kind of barely going right up there. So a normal curve means within 2 hours, your blood glucose level is back down very close to where you started at the normal level you started at. So that top one, that patient has Cushing's disease, a pituitary disease. The yellow boxes, that is a diabetic that's mildly abnormal. Then when you look at the triangle, they have thyrotoxicosis. The stars are normal. And then the gray one is hyperinsulinism. So this could happen with anorexia or Addison's disease. Different diseases can cause the spikes and the coming down. Okay, if it is just a 1 hour glucose screening test, which can be done typically with like our pregnant patients, the patient is given a drink that contains 50 grams of glucose. The patient blood specimen is collected after 1 hour. If the glucose result is greater than 140 milligrams per deciliter, then the patient has to go back and do the long test, which is the 3 hour oral glucose tolerance test. So this is just the 1 hour first. And if they fail that one, they have to go to the big one. Okay, molecular genetic testing. This includes a comprehensive list of tests to analyze the genetic information in DNA and RNA from tissue samples like blood, saliva, urine, feces, and organ tissue to detect specific markers using biochemical, cytogenetic, or molecular methods, or even a combination of those. Okay, why do we want to do that? Look at the second box there. Classifying an individual's genetic makeup can determine drug dosage suitability. This helps the doctors in order to treat the patients. If you look at the whole genome, you can also help find out diseases better than if you do, when you don't know anything about the patient. Okay, paternity or parentage testing. This is using DNA profiling in order to match up children with their parents. The parental testing can be used to determine either the alleged father or the alleged mother. The test to determine if a man is the biological father of a specific individual, that is the paternity test. If it is to determine if a woman is the biological mother of a specific individual, this is the maternity test. Okay, so used to, they would use blood every time, and they now can use that. Blood specimens are still the preferred testing, but now they use what they call buccal or cheek swabs, and this can also be done this way. Blood sample testing also includes ABO and RH testing if you're doing either paternity or maternity testing or both. Okay, therapeutic drug monitoring. You may notice this as called TDMs. This means you're testing drug levels in the bloodstream at specific intervals. So why do we do this? Well, we want to manage the patient, what they are given, the certain drugs they're given. You want them to be given only the amount they need to fix whatever the condition is. If it's an antibiotic, just enough to get rid of the organisms. If it is like a cardiac drug, for example, just enough to get rid of the symptoms. Whatever it is, you want to give them just the right amount to avoid any kind of toxicity. But what is another reason why we would do therapeutic drug monitoring? Non-compliant patients. Let's say that we've got somebody that says they are taking all of their medication, but they're not. Then we do therapeutic drug monitoring, because if they are truly taking it as they say they are, then there will be blood levels that they can detect when they do a blood test. So this is identifying whether they're truly taking it. Okay, therapeutic phlebotomy. This means we are going to withdraw large volumes of blood, usually measured by the unit like they do with the blood donor units, or approximately 500 milliliters. Only phlebotomists that have been specially trained in this can do this, or donor phlebotomists that work at the blood donor facilities can also do it. But it's used as a treatment for somebody that has a medical condition such as polycythemia or hemochromatosis. So I'm going to briefly tell you what these two conditions are, just so you know. Polycythemia means that the body overproduces red blood cells, and this over time can be detrimental to the patient's health. So polycythemia is the most common reason that a patient needs therapeutic phlebotomy. So what happens is the red cells are monitored in these patients, and every now and then when it gets too high, the patient goes in and has blood removed to keep their levels at a normal range. So they have too many red blood cells. Okay, the second condition is hemochromatosis. This is also called iron overload. So this is a disease where the patient has excess iron deposits in the tissue, especially the heart, liver, and the pancreas. This is the most common type, called primary or hereditary hemochromatosis, and it is caused by a genetic defect in iron metabolism that causes the body to absorb too much iron from the food they eat. There's a secondary that is non-hereditary, and this can happen from problems such as, let's say the patient needs multiple blood transfusions, then they can end up with this hemochromatosis, iron overload, just because they got too many transfusions. But also other hemolytic disorders, taking too many iron supplements, or just excess iron from the foods you eat if you just eat too much iron. But that's got to be an overload of iron. We're not talking about just a little bit. So occasionally these patients will need periodic removal of units of blood too, to deplete their iron stores, because the body uses the stored iron to make new red blood cells to replace those removed. So this just kind of helps the patient. Okay, this is a chart showing a dose response curve after multiple oral doses of a drug were given. So it shows you the peak and the trough. So I do need to talk to you about those two things, peaks and troughs. Peak levels means that this is the maximum amount that drug will get to. Trough level is the minimum amount. That's where you want to get that therapeutic range in. So when a patient takes a drug dose, the amount in the bloodstream starts to rise at the beginning, and then it peaks, and then it falls. So when it falls, it then falls to its lowest level, and that's the trough level. And the trough level is just before the patient is given the next dose. Okay? So when you're timing out these these drug tests, then timing is very important. You want to get it as close to that peak and trough as possible. So it is a team effort. It requires pharmacy to tell you when this go, or you to nursing to tell pharmacy when the peaks and troughs are, nursing to tell you when the peak and trough is, and then the phlebotomist, we are the key player. Okay, so we have to understand when the peak and troughs are and get the times. So peak levels are collected when the highest serum concentration is anticipated. So peak times mean typically 30 minutes after IV administration or 60 minutes after an intramuscular, like if they got a shot, or 1 to 2 hours after oral intake. So they've got a careful coordination between when nursing tells you they got their dose and then for you to time it out and know when to get it. Trough levels are monitored to ensure that levels of the drug stay within the therapeutic range. So the trough levels are the easiest to collect because they're collected when the lowest serum concentration of the drug is expected. Usually this is immediately before administration of the next scheduled dose. So it's very critical that you collect these at the appropriate times. These are serum specimens that have to be done accurately. Okay, toxicology. Toxicology is the study of toxins or poisons. This is usually involving forensics. So this is in crime investigation. So toxicology is very important when they're examining blood, hair, urine, anything else for the presence of toxins. Why forensically would this be important? Well, because let's say that someone has a car accident. Well, if they have a car accident and they suspect that that patient was drinking, then they need to know what the blood alcohol on that patient was in that car wreck. So that means that the police are going to be hanging around too to see what this blood alcohol level is on this patient. So sometimes they'll, the police officer has probably already done the breath alcohol, but they want the blood alcohol as well. One thing to keep in mind about these forensic type, especially these blood alcohols, in the lab you have to follow chain of custody, because if this is something like a blood alcohol and it comes back, let's say that car wreck, they killed a patient, then you could actually be called to court for this, because if you don't follow chain of custody, then this is going to track the specimen from the time that it was collected all the way out to the time that it was reported. And so you may be called into court to make sure that you followed protocol so that their lawyer's not saying that the specimen was tampered with in the lab. So as long as you're following the appropriate procedures, you don't have anything to worry about. Okay, skin preparation is important in blood alcohols, though. You're not going to use an alcohol-based disinfectant. This should pretty much just be common sense, because you don't want that on the skin, because in case there is a contamination somewhere, you don't want that to get into that blood tube and cause a possible alcohol contamination, because that's what you're testing them for. You're testing them for alcohol. So you're going to use tincture of iodine instead. If that's gonna, well, actually tincture of iodine does contain alcohol, so I take that back. You are not going to use that to clean the site either. What you are going to use instead is going to be what they call BZK, which is benzalkonium chloride, and sometimes you can use povidone iodine, because those two don't have alcohol in them. If you don't have either one of those specific antiseptics, if your lab does not, then just regular soap and water can be used in a tite. The actual brand name for benzalkonium chloride is Zephyrin chloride. That's an example of the brand name that you would use. But the specimen requirement is going to be a gray top sodium fluoride tube. You're going to fill that tube until the vacuum is exhausted, and do not remove the stopper. Okay, drug screening. Tests for drugs. These can be done at a forensic or a clinical laboratory. It's important to note the detection time for drugs in blood because they're dependent on a lot of different factors. Genetically, some people metabolize drugs faster than others. Also, body size. Men are going to metabolize drugs typically faster than women do, and men that have more muscles are going to, metabolize drugs more faster.
What are you doing with them?
Drug screening is required by many healthcare organizations, sports associations, and lots of companies. They may even do random drug screens, but they can detect a specific drug or they can screen up to 30 drugs. Typically, it's performed on urine rather than blood, but chain of custody is still required for these. Okay, trace elements. Trace elements test for aluminum, arsenic, copper, lead, iron, and zinc. These are measured in small amounts. Traces of them are in plastic, glass, or stopper material, and that can leach into the specimen. So you have to use a special tube called a special trace element free tube. This is a royal blue EDTA heparin or non-additive tube, but they usually have that royal blue top on them. Okay, tuberculosis blood test. This is your skin test that requires 2 visits where they do the little bubble in the skin under your right there on your inner arm. And if this is the case, this requires 2 visits. They will do one, and then approximately 2 weeks later, they will do another test. But if this is not good enough, you can also do blood testing, and that only requires 1 tube. And this also increases compliance. This is called an interferon gamma release assay, and this is specialized tubes called the TB Gold test. This is like a yellow top tube. This is what is drawn or called the TB spot test, if you're going to do a TB blood test. Okay, point of care testing. We're dwindling on down to the end now. Point of care testing is also known as bedside testing. This means you are bringing the lab to the location of the patient. An example of point of care testing that you might be familiar with is that when someone has diabetes, they do their own finger sticks. And in order to do the finger sticks, what are they testing for? They're testing for glucose in their blood. And they do these at their homes to monitor whether their insulin is working well or not. But it means that you are doing little short tests just there at the bedside. There is a short TAT, which means turnaround time. So this means you do a skin prick, a capillary puncture, you test the patient at the bedside, and the results go across automatically. Okay, you can have waived versus non-waived QC checks on point of care testing. Waived means that there is very little room for error. Non-waived means there are more steps and there are more, you have to be much more stringent in the way that you do things to get those to, be done correctly. Okay, point of care coagulation monitoring. This is where you are checking PTs and PTTs and INRs on patients, and you can also check clotting time and platelet function. So these are tests that involve monitoring, and not all of these tests are waived. Those that are waived have more stringent regulations. Remember, we said those have more rules you have to follow in order to do these. The actual coag monitoring test, you just need to be familiar with some of these names just because you will hear them. But one of the main ones I want you to note is the Coag-U-Check. The Coag-U-Check, there is a picture on figure 1116 in your textbook, and that is a picture of a Coagulation instrument that checks PTs and INRs on patients at the bedside. These are for patients that are on blood thinners, just to make sure that they're not getting too much blood thinner. Okay, arterial blood gases. These are called ABGs for short. This is where these are ordered on patients usually in emergency situations because the doctor suspects a critical imbalance in these analytes. So this is going to threaten whether the patient survives or not. That is why ABGs are ordered in emergencies, and electrolytes too. But arterials are the arterials that they're going to check. The blood gases are pH, PCO2, PO2, and SO2. The electrolytes they measure are sodium, potassium, chloride, bicarbonate, and ionized calcium. Okay, we also have what we call a multiple test panel that you can monitor by point of care testing. This is going to give you some commonly ordered stat tests like blood gases, electrolytes, hemoglobin. This is just a little tiny point of care instrument that tests for several things. Okay, some different other point of care testing instruments. You can just glance over these. You don't have to memorize these. BNP, bilirubin, cardiac troponins, CBCs, CRPs, glucose, hemoglobin A1Cs, hematocrit, hemoglobin, lactate, lipids, cholesterols, and rapid syphilis. These are just some other things that they do have the possibility of doing at the bedside. And this summarizes Chapter 11, which is special collections and point of care blood test. These at the very end, these last two slides just give you entry-level competencies that were met in this chapter. You can look over those. I will address any questions. I will put a box up on Canvas underneath this link with this video. And if anyone has any questions, you can put them in the box, or we will discuss them when we have the next class meeting in person. This next chapter 12 will also be posted later, but I will end this right here, and I will see you next time. Thank you for listening.